I was going to start with a brief apology for bringing the rain from Dublin, but a former colleague of mine who lives here in Sydney said it's been really hot lately, so I don't feel so bad. You can thank me later. So I work at Beacon Hospital. We're a small private centre in Dublin. We only have 2 clinics. We've been doing radiosurgery and SABR treatments for 10 or 12 years now. I'm going to speak today on how we've used the Line RT to really drive improvements in how we deliver those radiosurgery treatments. And I guess as a non-academic or non-university centre, I think if we can do it, pretty much anybody can. So this is just a wordle from the ASTRO 2011 white paper on radiosurgery. And you can see some of the elements that really jump out from it are precision and accuracy, which obviously would be fairly obvious for radiosurgery, IGRT, which brings in our SGRT, and then also quite prominent there is the patient, and I think this relates back to Julie's talk this morning about improving our patient experience. Probably not something we consider too often when we're starting these programs. And actually, interestingly, if you look through all these guidance documents that are available from ASTRO and AAPM, they actually hardly mention SGRT at all. They're really just given a passing reference. It's a paragraph or a line in most of them, which I think really highlights how rapidly SGRT has evolved in the last few years for use in radiosurgery. Okay, so what is it we want? We want to really minimize both inter and intrafraction motion. So we've heard a fair bit of this already this morning from our previous speakers. So get the patient set up accurately at isocenter and monitor their drift from that position during the course of the treatment delivery. Many of these radiosurgery treatments also have non-coplanar angles, which we can't image with standard onboard imaging, so a Line RT will help us with that. And then again, the patient experience, whether it's an open face mask or not using body compression or tattooless treatments, can help as well. I've just shown table 2 here from the AAPM report in 1995, which it's shocking to think it's almost 25 years ago now, but that was kind of listed the achievable uncertainties in SRS, and I think technology has really moved on since then, and I think if any of us were to run this algorithm for the technologies in our own department, it'll be obviously individually based per centre. I think our standard deviation of position uncertainty is it's going to be somewhere around a millimetre and a half. And this kind of fits nicely with the ASTRO practice guideline from a few years ago, which states that the treatment delivery should be accurate to within approximately 1 millimetre. So the question then is, does a Line RT meet this requirement? We saw from Dr. Lawson's presentation this morning that it does. So there are multiple phantom studies that have shown that a Line RT isocenter location to within a millimetre. And there were several studies that have compared it to existing X-ray imaging technologies such as OBI or Exact Track from Brain Lab. And all have showed that it's at least as good as those. And then in terms of clinical outcomes, we saw some papers this morning as well, and these 2 papers are also from University of California, San Diego, which showed no difference when using a Line RT for SRS compared to conventional frame-based or frameless SRS. So we can say that it's at least as good as the existing technology, and in terms of our radiosurgery treatments, what we've been doing before, it will not disimprove by using a Line RT. But I think it's also fair to say that it doesn't replace what we have. So we use a very similar protocol to the one that Dr. Lawson demonstrated this morning. So for us, cone beam CT localization is still the gold standard. But by using a Line RT as a complementary technology, we're able to drive improvement in our treatments. And I think Mike just listed most of these for me in his last couple of slides. So patient positioning and initial setup will improve using a Line RT. Monitoring of intrafraction patient movement during the treatment is really important, and probably the key benefit of it, I think. It also allows for respiratory management. We'll hear today about its use in DIBH for breast treatments, which is well established. And a lot of centres, or some centres, are using it now with gate RT for phase and amplitude-based gating that we would have traditionally done with varying RPM. And then the last two points here really apply to pediatric patients, so it's reduced imaging dose and reduced anesthetic needs, which can also be very important. So just at our hospital, we've been treating intracranial SRS for almost 12 years now, 11 and a bit. And we have a typical workload, majority are brain mets and some benign lesions, trigems and vestibular schwannomas. But we use Align RT for all these patients, regardless of their lesion type. We treat them on a variant trilogy Linac, which is now 12 years old, but does have a HDMLC and cones. And we just installed a TrueBeam Edge, which I've been acceptance testing on Monday this week, so that when that comes online, we'll use that for radiosurgery too. However, we installed Align RT on our trilogy back in 2014, and we treat about 70 patients a year with that for cranial SRS. And it's actually the largest cranial SRS series in Europe or outside of the US using Align RT, to the best of my knowledge. And what we can say is that it's very well tolerated for all our patients. I think over 99% of our patients were successfully treated using Align RT. I got count on one hand the number of patients who we didn't treat, and that was more due to their clinical performance than anything to do really with Align RT. Our workflow hasn't really changed because we use Align RT. So again, it's CT sim, treatment planning. We saw this already this morning. We have pre-treatment QA, and then we use Align RT for patient setup and imaging, and then for monitoring during patient treatment. And it's this last one I want to kind of just have a look at now. Just a very similar workflow to the one presented earlier as well. So we set up to the DICOM surface, and we acquire a cone beam CT for localization. Just one point that about the cone beam CT, because the OBI arms are at 90 degrees to the gantry, so as it rotates around the patient, there is, for a second or two, a time where the two lateral cameras get blocked, and so you have no signal coming back to the Align RT cameras. And we did a bit of head scratching when we started off about, well, what if the patient moves during this time, and how do we cope with this? So what we do is we just make a note of the real-time deltas at the start and the finish of the cone beam CT. And if the patient has moved more than 0.5 millimeter during the acquisition, we'll actually just reset them up and go back to the start. So, but we found, and I'll show you some data in a couple of slides' time, that this actually happens very rarely. Most of our patients are really stable. We're using an open face mask, so again, we're back to this idea of patient comfort helping to minimize movement. We match the cone beam CT. We don't have a robotic couch on that machine, so we apply 4 degrees of freedom shifts and then capture a new reference surface. But we do review the cone beam offline for the other 2 degrees of freedom, so pitch and roll. And if either of those are greater than 0.5 degree, we'll go back to the start and reset up again. Again, most of the time they're not, and we can just continue on with the treatment with Align RT monitoring the patient position. So just looking at our open face mask stability. So for our first, I think 78 patients here, we took those deltas that we recorded before and after the cone beam acquisition. And what we found was that most patients don't move. So we only had to re-cone beam CT 5 out of those 78 patients. So the patients were really stable in the mask. Comfort was very important. When we were early in our experience, we had, I think, 2 or 3 patients who had been with us before. They were frame-based patients and then came back, had the same bite array that you saw with Dr. Lawson earlier on, and then came back again and had the open face mask. And it was only 2 patients. It's fairly anecdotal evidence, but they were raving about how much better the open face mask was compared to the other systems. So as I noted, we set up with Align RT, we acquire cone beam CT. So just looking at the nature of the shifts we saw with the cone beam CT, and the majority of them were less than 2 millimeters, particularly in the vertical and lateral directions. What we can see here, though, is longitudinal shifts drop down to about 82%, and that's because the longitudinal shift is also sensitive to this pitch of the patient, so rotation in the cranial caudal direction. And it's actually very similar to the paper that Dr. Lawson showed earlier on from Laura Savino et al. I think their average shift was around 2 millimeters. And so this pitch is pretty much as you would expect. We're more sensitive for it at the front and the back of the brain, basically. So frontal lobes and occipital and cerebellar lobes lesions. Again, some data here from our first, cohort of patients. So it's about a year of our first year of treating, and we saw that about a third of our patients had pitch measured at greater than half a degree when compared to a line RT using cone beam CT. And then recently we've been looking at the effect of the advanced camera optimization. Another talk later on will explain what that is. But we saw that the impact of the ACO has reduced the proportion of patients that are pitching greater than half a degree from about a third of our patients to a quarter of them. And certainly our translations have improved dramatically, so 100% were within, or the vertical translations within 2 millimeters, and well over 90% of the long and the lat. So whether all of that's due to the advanced camera optimization and how much of it's due to our improving user experience, or we're getting better at making the masks and drawing the ROIs, we're parsing that data, so we might have some results for that soon. So this is a cranial case study, which I think strongly relates back to Julie's talk this morning. This is a 52-year-old female who had breast cancer and presented to us in March 2018 following resection of a right cerebellar metastasis, which you can see in the MRI here. So she was booked for 24 gray and 3 fractions, as it was quite a large lesion. Unfortunately, this patient was extraordinarily claustrophobic, and she was adamant she wasn't having whole brain radiotherapy, but was also adamant she wasn't having a mask made. So put us in a bit of a bind. We tried an open face mask. She couldn't tolerate that either. So we use a double shell positioning mask from Macromedics. So we treated her using just the occipital part of the mask only. So we had a very incomplete immobilization. So to allow for that, we increased our PTV margin from our standard SRS margin of 1 millimeter to 5, and reverted back to a standard 30 gray and 10 fractionation. But nevertheless, even with that, we still needed real-time monitoring of the patient position to allow us to proceed with the treatment. So what we found was that the patient was actually really comfortable during the treatment. And so this actually really helped to minimize her movement on the bed. And the motion was observed to be less than 2 millimeters for all 10 fractions of treatment. So as it turned out, we're probably a little bit too conservative with our PTV margin. We probably could have reduced it even more. But certainly without a line RT, we wouldn't have been able to treat this patient at all. Unfortunately, she presented again 7 months later with a new left cerebellar metastasis, which thankfully was visible on CT. I don't know if that appears on the slide, on the screen or not, but because she actually refused an MR scan this time. Was quite close to the brainstem. So we had a 2 millimeter PTV, and we had a prescription of 25 gray. A little bit more aggressive now because we had this experience. So 25 gray and 5 fractions to the PTV with a 30 gray simultaneous integrated boost to the GTV. And again, we treated her without any issues, really. So this is just a chart or a graph of her real-time deltas during treatment, and you can see for most of the treatment they're within plus or minus 1 millimeter of isocenter. Apart from that large jump there where I think she coughed or moved her head up, so we re-imaged at that point and had her set back up. But she maintained a very stable and very minimal patient movement throughout the treatment. So with using a line RT, we're able to safely deliver 2 treatment courses to this patient's brain, even though she had no mask. So I'll quickly move on to our SABR program. We've been doing SABR for 10 years. We average about 150 patients a year. So when we set up, we had the variant RPM system for respiratory management, and we used the medical intelligence body fix system with this cellophane sheet that Mike referred to earlier. And then around this time last year, then we started to use Align RT for intrafraction motion of all our SABR patients, which meant we had to get rid of the body sheet, which I think all of our therapists were happy to see the back of. Yeah, actually we introduced it for our non-lung SABR patients because we're still using the variant RPM system. So principally for spines was where it was really important for us, and some of these abdominal, like liver and adrenal lesions. So as with our SRS program, cone beam CT localization and using Align RT to track the patient movement during the treatment. And again, I'm repeating what was said before, but Align RT really acts as an extra set of eyes while the cone beam CT matching is being formed. And that's really a time at the console when all the therapists or the physicists' attention is solely focused on the cone beam CT match and the soft tissue matching, and the patient could be doing a dance on the bed and we wouldn't really notice it. So having something to watch the patient first while we're doing that is a real comfort. And also at our centre we have physician review online before any SABR fraction, and with the best will in the world, these physicians don't come down when we call them within 2 or 3 minutes most of the time. So again, having the cameras to monitor the patient position, and as Mike explained, checking that drift from isocenter while we're waiting on that image review can be really beneficial. As with any Align RT, the ROI selection, of course, is critical, and we find that this is really not only patient but operator dependent, and it's something that we spend quite a bit of time training our therapists to do. A bad ROI is going to make it difficult for you to have a successful Align RT monitoring, and there are some general rules. Obviously don't include anything that's not part of the patient, and try and use bony or rigid structures only. And what we've also found is that, so as we're using the body fix device, traditionally we would have made the sides of it up really high to hold the patient, but now we want to get our ROI to come down to the side of the patient, so we don't make the body fix so high anymore. So there's been a bit of a trade-off for that, and it took a bit of convincing for some of our therapists that was actually a good idea. We use gated capture and the time threshold for respiratory motion, and actually we seem to use this a lot for a lot of our prostate SABR patients because we can see their abdomen moving with respiration. So, but again, that's going to depend on the ROI for that individual patient. So these are the standard ROIs you get in the training manual from Align RT, so I won't dwell on them too long. But again, the usual rules, don't include things that move and don't include any mobile skin or tissue. And don't include any excessive tissue. I think it's a nice way of putting it here. And then I'll just finish with a couple of more SABR case studies just to show how we've found Align RT beneficial for those patients. So the first up was it's a 67-year-old male prostate cancer patient who was treated with external beam and brachy and returned 10 years later with a PET-CT confirmed solitary sternal met. So the decision was to treat this in a single fraction, 18 gray to the PGV with a 22 gray simultaneous integrated boost to the GTV. Again, we were using a body fix system to mobilize the patient without the body sheet, so that we don't cause any issues for the Align RT cameras. We did do a 4D CT. The sternum wasn't moving due to free breathing, so we just proceeded with a fine cut 3D CT. And we set the patient up with Align RT, then did a cone beam CT localization. Got a really nice match, as you can see there. Virtually no moves after the Align RT setup. I think it was a millimeter or something. So we applied that. We're waiting on our physician to come down and just sign it off online. When Align RT detected that the patient had actually moved, you can see the jump here in the deltas. We actually had a therapist who was looking at the patient on the CCTV at the time and swore blind that the patient hadn't moved. So we took a KV image just to confirm that, and there's the DRR, and you can see quite a big shift there. So it actually turned out it was a 7mm long shift and a 4mm vertical shift that we just didn't see on the in-room monitors. Obviously, this was a single fraction SABR treatment, so there would have been a fairly significant dosimetric effect if a line RT hadn't detected that movement. Actually, as it turned out, that was our first patient that we used a line RT for monitoring for SABRs, so really fortuitous. Just the plan, the original treatment plan on the left with the plan with that shift on the right, so, you know, fairly significant under dosage. And then our last case study, it's another bone met. There's a 58-year-old female with metastatic breast cancer who had a PET confirmed single rib met, which was to be treated in 24 gray and 3 fractions. So for this patient, we were using variant RPM for breath hold and the line RT for intrafraction monitoring. So fraction 1, we had completed the cone beam, done our image matching, had it signed off by the physician, and we're about to beam on when a line RT recorded a 3mm shift in the vertical direction. And actually, interestingly enough, the RPM baseline only changed by 1 millimeter. Nevertheless, we took a new cone beam CT, which we matched here, and you can see the deltas down there, so to confirm the actual vertical shift, of 0.3 of a millimeter. Fraction 2, patient did the same thing again. And unbelievably, it was a 3mm vertical move on the second fraction. This time was during the treatment delivery, and we saw no shift in the RPM baseline. So again, as with the first fraction, we took another cone beam CT, and this confirmed that move. So this got us thinking, you know, certainly a line RT is more sensitive to patient movement, in this case anyway, than the variant RPM, and kind of makes some sense when you consider the RPM is just a single point, just being tracked up and down rather than the patient's surface. So we have a clinical audit committee review of moving completely to DIBH using a line RT, which hopefully we'll get word on in the coming weeks. So I'm going to stop shortly now. So I think it's fair to say line RT is well established for use in cranial SRS. We saw that this morning with Dr. Lawson's talk. Its use in SABR is certainly increasing, and I would expect to see some clinical papers in that regard coming out soon. We still use it complementary to cone beam CT localization, not as a replacement. But when you do that, you can use it to improve your treatment deliveries in terms of faster, more accurate setups, real-time monitoring, which is the key thing, as I think I've shown here. It does improve patient experience, and it can now be used for respiratory management. So it's well established for DIBH, but also now can be used for phase and amplitude-based scaling. And I'd just like to acknowledge a couple of colleagues who helped with this talk. Thank you all for listening.